Today alone, we'll be discussing everything from how gaming and social networking are changing the healthcare landscape to how new platforms are delivering easy ways for us to stay healthy, even in our cars and our kitchen. We'll also take a look at how leading companies are helping consumers understand and best utilize the increasing amount of data sent their way with all of this advanced technology at their fingertips. Patients are consumers, and there's a very important session this morning discussing the challenges around mobilizing them to support the digital health movement. Tomorrow, you'll see everything from digital health's connection to public policy, new ways to manage aging, our changing relationships with our doctors, and how technology can be a cure for the common couch potato, and lots more. If you want to hear about some jaw-dropping innovations, you definitely come to the right spot. It's a rare chance to have so many industry leaders and thinkers from such a wide variety of companies and disciplines under one roof. So as always, I encourage you to take full advantage of this opportunity and of course network like crazy. And don't forget to head downstairs to check out all of this technology in the flesh. At this point, I really want to give special thanks to our platinum sponsors. I've personally liked working closely with each of these companies: AMP Plus, Continua Health Alliance, Ideal Life, Life Technologies, Quality of Life Technologies, Scientific American, and United Health Group. Now, before I introduce our opening session, I'd like to cover a tiny bit of housekeeping. First, the basics. You'll notice there really is very little time between sessions on our schedule. So I ask that when each panel is complete, take your conversations outside and give the next panel the undivided attention they deserve. Second, if you have a smartphone, please set it to silent during our sessions. Oh, I missed an important slide. Sorry. Second, if you have a smartphone, please set it to silent during our sessions. That said, I know many of you, like me, are mobile junkies, and I encourage you to share your experiences on Twitter using hashtag #DigitalHealth, or you can follow us at DHSummit on the side for updates as well. Third, and this applies to all of our sessions today, if there is ample time for audience questions, I ask that once our moderator says so, please approach the microphone right in the middle of this aisle. And I ask that you keep your questions to just that, questions. It's very, very important to kind of take your networking opportunities outside and leave this room for the discussion. Thanks. I'd also like to take a moment to thank our gold sponsors, which have incredible exhibits downstairs, well, all except one of them: AARP, Alcatel-Lucent, Audax, Body Media, Qualcomm Life, and Tanita. Now on to the really good stuff. What's in store for this morning? Our first session is about vision. Rather, it's about being visionary. What's the big picture for digital health and its possibilities? Where do we want this all to go, and how do we get there? Just how much do we need to shift the paradigms around healthcare and wellness to take advantage of the technologies that are evolving? I was lucky enough this year to work with a truly visionary media partner, Scientific American. For 167 years, they've never stopped working. Scientific American has been advancing the conversation of science and technology, and their decades worth of experience was paramount to helping us put together this very significant opening session. Our panel today is moderated by award-winning science journalist and author Ira Flatow. Many of you already are familiar with Ira's work, and certainly his voice, as host of NPR Science Friday, a weekly call-in program that connects listeners with scientists for informative discussions about science, technology, health, space, and the environment. On TV, Ira has presented cutting-edge science stories on a range of programs, including the Big Ideas and Newton's Apple series for PBS, as well as science reporting for CBS, Westinghouse, and CNBC. He has been awarded numerous honors for his work, including the Nuremberg Prize for Science in the Public Interest, the National Science Board Public Service Award, and most recently, the 2012 Isaac Asimov Science Award. So with that, I give you our visionaries. Take it away, Ira.
Thank you very much for that introduction, and thank you all for coming here to this opening session. And as always, I'm usually the stupidest person in the room, but that's what I do for a living. So I'm very happy to have a range of the smartest people, some of the smartest people in the world up on our panel discussion today. And you can see their names up there on the slide. We are the opening panel, and as the opening panel, I think that it's part of our job to set the pace and set the tone for what comes later on in the sessions that follow. We're going to be talking about the future of digital technology, how it's changing the way that you interact with your doctor, and your doctor interacts with the healthcare provider and the your insurance company, and how that all fits into a larger context of our society, because we also need to talk about how does the society embrace and work within all this quickly changing digital technology that we have with us. The face of the Consumer Electronics Show is changing, I think, a bit to genomics. If you walk around, as I have been yesterday, you get to see some of the quote-unquote gadgets, these new gadgets that are coming out. Some of them remind me of the Star Trek tricorder. Remember that thing, that little thing you can wave on somebody's body? And we'll talk a little bit about that later with some of the presentations. And you could sort of diagnose all their ailments and read their blood pressure and their respiratory rate. And these gadgets are here already and are being used and being developed. The news this week, the big news this week, of course, in the world of genomics, is the announcement by Life Technologies of a machine that can actually decode the human genome for under $1,000. And Greg Lucier is here he's chairman and CEO of Life Technologies, and he'll tell us, I hope, a little bit about this machine and what possibilities it has. Of course, if you're in the engineering world or you work in any kind of science, you know that you never get something for nothing. So along with knowledge and along with new technology comes a Faustian bargain of how do you use this stuff? How does it impact the public? What happens to the human genome once it's decoded and let loose into the public? These are the kinds of issues we will be discussing, I'm sure, within your questions and up here. Plus there are also bigger issues that people will be discussing amongst themselves and amongst their legislators. It's also going to create a flood of data. All this stuff that we're creating now, all these new machines and gadgets, all this data, what do we do with that? How do we decode it? How do we deal with it? How do we massage it? Where does it go? We need to talk about how we take care of all this data. What does it mean for a doctor-patient relationship, for example? How can all levels of society be involved, be included? How about underserved populations? Are they going to be left out with all these new devices? What will all of this do to the price of health insurance? How can we make health insurance cheaper for health insurance companies, for providers, and also for us, who pay for the health insurance? And what kinds of public policy initiatives, the public involvement, will be needed in this changing world? We're really at the beginning of a new era. You know, it's like a black box. When you're inside of it, you really don't see it from the outside and see how big it is and what it's made out of. We're sort of in that black box now in digital health. And so I'm glad that the summit is here to help us understand what's going on inside that black box. And as I say, we have three panelists who can answer lots of these questions. And as you were told, there's a microphone here that we'll go to for your questions. Don't be afraid to step up to the mic when it's time. You feel like you have a question. Because what happens is that people are very shy about being the first one up there, so they wait to the end. And then there's a flood of people and no one gets their questions in because they were afraid to get up there early. So get up to the microphone quickly. The format today is going to be, I'm going to introduce our panel members. As you can see, they're up there on the screen, but they're each going to provide a 5-7 minute, however long they'd like to speak, presentation of what they do and about the important work that they do. Greg Lucier is chairman and CEO of Life Technologies. His company, as I said, made that announcement this week. It's one of the largest providers of systems, biological products, and services supplying scientists around the world. Eric Topol, Dr. Topol is director of the Scripps Translational Science Institute. He's vice chair, West Wireless Health Institute. He's author of a new book that's out now called The Creative Destruction of Medicine, How the Digital Revolution Will Create Better Health Care. Just released, right? It's out in bookstores and Amazons everywhere that you'd like to get one. Download it digital, I'm sure, right? Absolutely. Reed Tuckson, Dr. Tuckson is Executive Vice President and Chief of Medical Affairs for United Healthcare Group. He's responsible for working with all the company's business units to improve the quality and efficiency of health services. So I'm going to introduce and have them come up to speak in that order. And let me ask Greg to start off.
Well, good morning, everybody. It's really great to be here and share with you some very exciting news that we think bridges the gap between what was once just a dream a few years ago to actually having impact on each and every one of our lives. And that is this device we announced yesterday that will be able to read the entire human genome in a couple of hours and for about $1,000. And this is really an amazing piece of technology. And since this is a technology show, I will get to in a moment how it works, because I think you'll find it actually quite interesting. But maybe first is just to set the context for what's going on here in terms of reading a genome and why is yesterday's announcement so important. About 10 years ago, there was an international human genome effort project to read the first human genome. That's all 3 billion bases of the DNA that you have in your cells. And it cost about $3 billion. It took several years just to get the first human genome decoded. If you fast forward the clock and you go forward 10 years, last year you could read a human genome for about $5,000 to $15,000, but it still took upwards of a month or more, as Eric Topol could convey to you, to decipher what it all meant and actually get something that could be then acted upon. And these were very big machines, and certainly we're one of the providers of those, and quite frankly, you needed to have an equally big PhD to operate it. It's just a very complicated device. So what we announced yesterday, though, speeds the clock up even more, and in fact, it's moving at about 4 times faster than the venerable Moore's law that governs the semiconductor industry. If you just say 3 billion 10 years ago, and now $1,000 in a couple of hours, this has been a remarkable rate of technological innovation. And the big breakthrough that has now taken place is that we have been able to take these giant pieces of machinery and essentially reduce them down onto a semiconductor chip that's about this big. And it is the very first time you've also been able to bridge the chemical world of reading molecules in your body and converting it to digital information, hence why we're here at a digital health show and forum, and then potentially do something with it. So now the next question is, what does this mean in the world of medicine? Well, I'm going to defer to my colleagues here to the left, who are both MDs and certainly are in the world of medicine to a much greater degree than I am. But I would just simply say that at least how we think about now what this technology unlocks is the possibility of really moving medicine into the genetic age. And we think this is an irreversible course where we're going to be probing, interrogating ever deeper at the molecular level of what's going on in your body to solve disease at a much, much earlier stage. And of course, the very first disease that I think we'll be going after is cancer. Cancer is a disease of the DNA, and therefore it just makes kind of obvious sense that now that we can read the DNA very specifically and quickly and economically, we can then potentially act upon it. And certainly we could potentially do that much earlier in the phase of cancer before it gets completely complex and your DNA completely rearranged, and then it's just very hard to act upon. And so that's how we think about what this technology is going to unlock, is first in cancer, then many other indications that allow us to get these answers much faster. We think fundamentally in the next few years, we're going to understand the driver mutations, that is the defects in your DNA that are at the origin of your cancer. We're going to see them much, much sooner in its advent into your body. And then potentially and hopefully there are therapeutics that could be rightly prescribed for you so that we're not prescribing the wrong drugs and they act upon it, they do something for you, and you feel and obviously could be potentially cured. Now, having said that, we think cancer will ultimately be more like HIV, where it's a constant managed disease that as your DNA then does evolve in your body, that future drugs will be required to keep it in check. But again, I guess I'm getting into medicine. But I would just simply say this technological breakthrough is a very big deal. Because heretofore, before this point, the machines were too big, far too expensive, took weeks, if not months, to get the results. And now literally this machine is at the size of a printer that could be on your desktop. A clinician or a technician just pushes a button by putting in the sample, and a couple hours later you have the results. We have pushed the limits of computing to get all of that information back into a decipherable report. And again, we see a clinical encounter taking place in the world of cancer in the very not too distant future, where you come in on Monday, you get worked up, the analysis takes place overnight, and then the next morning the oncologist is sitting down with you, telling you about the mutations they see in your DNA, and hopefully being able to prescribe a therapeutic that will work just for you. We think that's the world of personalized medicine. We think this is an incredibly interesting, exciting time in terms of how health becomes digital, becomes genomic, and we're just really pleased to be able to play a role in it. Thanks very much.
I'm sure we'll have a lot of questions. We want to get into those details about how this machine works, and can I get one from my own basement? That sort of thing there. Do try this at home? No, you don't try this one at home. Our next speaker is Eric Topol, and you can see his name up on the list. What that doesn't show you is are some of the honors that Dr. Topol has been awarded. He's been elected to the Institute of Medicine of the National Academy of Sciences. That is not an easy thing to do. It takes a lot of achievement and experience over your lifetime to be elected to the Institute of Medicine and become a member of the National Academy. He's also named Doctor of the Decade by the Institute for Scientific Information, and he's now creating more new and more effective ways to treat patients, ways that will dramatically bring down, we all hope, the costs of healthcare, and maybe he'll tell us some stuff about that. Dr. Topol.
Okay. Well, thanks very much, Ira, and it's great to join this panel and join you here this morning. First, I want to start off by congratulating Greg and Life Technologies for really what is a remarkable achievement. Having been involved with the whole sequencing era for many years, what was announced this week is extraordinary. And the whole idea that Greg has laid out regarding how, for example, in the near term, someone with a newly diagnosed cancer would have their therapy individualized rapidly and an affordable, much less than typical scans that are done for cancer today. This is really an exciting time here in 2012. And so that actually bespeaks the larger problem we have, is that our medicine today is not individualized. I hate the term personalized because it sounds like a concierge thing, but individualized is the one I favor, because each individual is unique. We have our own biology, our own physiology, our own environment, and the way medicine is practiced today couldn't be further from that. Everyone's supposed to have mass screening. All women age 40 have a mammogram every year, for example. All medicines that we give them to all the people with a particular diagnosis at a particular dose. We don't have any adjustment for individuality. So now we have a new world, a reset, and actually what I think is really the rebooting of medicine, and that's why I picked this Schumpeter term, creative destruction of medicine, for the book that is pre-released here at CES, officially out at the end of this month. And the whole concept is that we can get the data, whether it's the sequence and the biologic data of all the omics, is not just the DNA sequence. Obviously, it's the proteins, it's the metabolites, it's the epigenome, all these omics. But in addition to the biology, we can understand the physiology. I'll show you a couple of examples of that, as well as the anatomy through portable, for example, high-resolution ultrasound as one technique. And this creates a comprehensive panoramic view of each individual, what I would call high-definition man, which we've never had access to before. So, for example, if we were interested in somebody's blood pressure, I'm a cardiologist, I see patients every week with blood pressure. Most every patient I see has high blood pressure. I say, can you get us some value so we can adjust your medicine? So more than 50% of people who have hypertension don't have their blood pressure adequately regulated, and they were sitting ducks for a stroke or a heart attack. And so if you can get that data not only more frequently, but how about every few minutes if need be, and even during the night, even when the person's having emotional upsetness or an argument, that's a whole new window we didn't have before. And the same for glucose and for heart rhythm and so on and so on. So now let me just show you the fact that we can capture this data now and in a seamless way. So actually, this first device I'll show you is invented by Dr. Dave Alpert from Oklahoma, who's here in the audience this morning. And it actually gets your cardiogram on the phone. In fact, when I see patients in the clinic, I don't even do an expensive cardiogram. It's for free, right on the phone. And basically, it's an add-on to the smartphone. It has sensors in the back, a case, and if I just pop this on my phone, what I can do is call up that AliveCor app, and I'll just fasten this in here, see it, and then I can just put my fingers on the back. And you probably can't see this because I need sunglasses to stand up here, it's so bright. But it's actually my heart rhythm. And I can put this on multiple leads on the chest, the sensors, and get a heart rhythm. It's really pretty remarkable. We've never seen a cardiogram right on the phone. Now, another thing I wanted to show you real quickly is, how about diabetics? There's 400 million diabetics on the planet, and there's over 1 billion pre-diabetics. No less, all of us would like to know what our glucose does throughout the day if we could get that kind of education, because it really changes your lifestyle when you're following your glucose every minute. I have one of these sensors on right now, and here's a phone, the first phone ever that can get your glucose right on your phone every minute. It's a product of Dexcom. And so if I just turn on the phone, I just put it right here, and this is my glucose right now. It's a little high, 120. I had a couple of those bread things in the back. But besides that, I can look at my plot for the last day. And besides that, I can send all this data to a doctor or to my Facebook friends, anywhere I want. Now, that's a whole new look. And the last thing I want to show you, and that's, of course, with all this digitizing physiologic data, it's not just any vital signs, your brainwave data, anything. And then this is what something is an outgrowth of the data that can be generated from DNA sequencing as we learn the pharmacogenomic interactions. Because we spend over $300 billion a year for drugs in this country alone, and most of that, believe it or not, is waste, because we don't match up the right drug or the right dose with the right patient, and we also induce horrendous side effects that result in hospitalizations. Well, how about if you know the particular variant in the genome, and you can test that with a handheld genotyping device, which is what this is, very quickly, within minutes. And this is a product of DNA Electronics, and there's other handheld genotyping. This is not sequencing. This is just looking at one variant base, but it's the key one for doing prescriptions and matching up things precisely. Now, the last thing I want to just mention is, how is this this whole new digitization of man and rebooting of medicine going to occur? Is it going to happen through the medical profession? No, I don't think so, because this is a profession that is very resistant to change, incredibly resistant to change. So I think that the only way this can go forward is through a consumer health revolution, because it's the data that each person has. For example, in the New York Times this morning, there was an article about should patients have access to their medical records and notes. Why could that even be a question? It's your health, it's your records. You shouldn't have access to it? Well, that's the kind of problem we have with the medical profession is the doctor knows best, the kind of priesthood attitude that's been there for a long time, and we need to change that. And consumers can come together. We know we're at this point in our civilization. We've seen the Arab Spring, we've seen the Occupy movements, we've seen all sorts of ways through social networking that people have come together like never before. And that's what I'm hoping we can spur here with some of the discussion this morning. Thanks.
Yeah, that's some interesting things to think about. Our next guest is Reed Tuckson. He's also an MD. He also is an active member of the Institute of Medicine of the National Academy of Sciences. He's a member of their Committee on the Consequences of the Uninsured. And he currently serves as the board of directors for several national organizations, including the National Hispanic Medical Association, the Alliance for Health Reform, the American Telemedicine Association, the National Patient Advocate Foundation, among those that he serves on. He was featured on the cover of the February 2009 issue of Black Enterprise magazine and made one of the 100 most powerful executives in corporate America. So you want to know this guy. Dr. Reed Tuckson, welcome.
So let me sort of pick up a little bit where Eric left off about this revolution. There absolutely has to be the recruitment and the engagement of a whole new set of capabilities and competencies outside of healthcare. We are in deep trouble. Be very clear about America's health system. That being said, I am so excited by the possibilities, but I am not seduced by the technology. I keep my mind focused on what are we trying to achieve? What are our goals? And what are the challenges that we have to overcome? Technology for technology's sake is not exciting. What's exciting and interesting is how we are going to apply these things. We need greater precision and greater value in how we do at least three key things. Number one, how we are going to enhance the health of populations, how we're going to, number two, give people access to personally appropriate care that drives up quality and that takes costs out. And number three, ultimately, at the end of the day, probably the most important context is to manage the escalation in healthcare costs. Please understand that all of these conversations occur within a very clear reality. The escalation in healthcare costs has got to stop. What we heard from Eric is important because these are examples of things that at their fullest expression and intelligently used will help to decrease cost. But know this, the biggest cost drivers in healthcare today are unit cost escalation for devices, technologies, for labor, and for the use of places like hospitals. That's where the biggest drivers are that are causing America to have the extraordinary problem with cost escalation that we have. And by the way, even though we talk about cost escalation, it has almost become a cliche. You must understand how absolutely imperative it is that that be dealt with. This gives us a challenge for this meeting, but it also gives us an opportunity. The other place where costs are going up is because of utilization. And so we're going to have to be very clear about how we use technology, how we use it to obviate the need for medical interventions because we keep people healthier and not getting sick, and that we help them to not suffer from the complications of disease once it becomes manifesting. My point is this. Discipline will be required under any rainbow, wonderful blue sky scenario about how these things get done. Discipline because somebody at the end of the day is going to pay the bill. Consumers will pay a lot of it because many of the things that you're here to talk about are going to be things that consumers themselves will purchase as a part of the normal process of living. What I love about the revolution in digital health is that I am integrating health things that used to be called sort of health just as a normal function of my life, my apps, my mobile apps, the way I engage my iPad and my smartphone. There are things that I'm doing just in the process of living that don't have to do with reimbursement for medical care services. But at the end of the day, I am still paying for them. The amount of money that consumers are paying for health and the availability of discretionary resources are significant. And so you've got to be very clear that at the end of the day, somebody is paying, even if it is the consumer, but as these things roll into the delivery system, somebody else's dime is involved. And there is no more room in the cost curve to accommodate things that don't add value. So there is a discipline. I worry when I say that, because the last thing that I want to do is to put a heavy-duty burden of value proposition that stifles innovation, that diminishes the flow of venture capital dollars into these sorts of innovations. So there is a balance, and we have to be very clear. Let me just quickly, in the last couple seconds, as we just sort of helping to set up some of the conversation, I tell you where I'm really focused. I'm very much focused on this notion of prevention of disease. I hope you do realize the level of tragedy that is befalling this nation. A tsunami of preventable chronic illness washing over a delivery system that is already unaffordable for most Americans. The number of people who are obese, there's not one state in America where there are less than 20% of its population that are obese. Now 27.5% of Americans are obese. We are headed to 43% by 2018. Just imagine what that means in terms of the magnitude of disease and the economics involved. Diabetes, I hope that we don't have to have all these people using Eric's new device. 8.7% of the population is diabetic. That's up from 8.3. The numbers are moving. We will be at 1 out of 5 conservatively diabetic by 2020. Frightening realities. You can either solve it on the front end, or we can pay for the apps and the interventions around monitoring glucose and all the drugs and so forth and so on. So we've got to deal with that, which means we need to have this information that allows us to understand who is at risk early and then be able to intervene. Personally or individually available, what is the level of risk for each individual? Now, we have a lot of data now that helps us to identify who is at risk, and more data to come. The question that has been asked is, who should have access to that data, and why? And so the issue of trust becomes essential. This whole field is going to be balanced precariously on the pendulum of trust. And therefore, there is an ethic to what we are doing in this room and at this meeting that must be highly attended to. Clinical decisions are second, and I think a lot about those very importantly. This revolution that Greg has described, and congratulations to them and what they have done. The amount of data and information that he is going to now make available on top of all the other data is a huge cognitive challenge. Our brains are the same size as they've always been, except for a few of you. The number of facts per decision that a physician must make, and now a patient engaged with a physician must make, are extraordinary. It used to be we would only have information in terms of facts about me as a physical structure. Then all of a sudden we had information about me in terms of the basics of genetics. Then it was functional genetics. And now it's proteomics. The curve of information is extraordinary. Nobody is smart enough to figure out how to use all of that and process it. So the actionable intelligence, the point-of-care decision-making digitalization revolution is going to be huge. So I'll just leave those as sort of two things. I've got a few others that I hope that we can get to in the conversation. But what I sort of summarize, ending exactly at 5 minutes, Mr. Moderator, is let's be very excited. I am a total fanatical cheerleader for this movement. But if we are not focused on what we are trying to achieve, the goals of these things, how they will integrate with other pieces to be able to make sense out of, to solve a problem, to move us forward. And if this movement, this revolution, is going to give us information that we do not know what to do with, that we go chasing after zebras running all over the landscape, oh, I got to have this diagnostic test to check to see whether I got this because my profile indicated that I may be at high risk with the statistical probability of such and so that I may have that, so I got to get this nuclear imaging procedure and this engagement and this lab test. All of a sudden, we just took a healthcare system that America cannot pay for anymore, and we just put it on steroids. That is a moral, horrendous conundrum, one that we cannot allow happen. And yet, as I say that and sit down, I will come back to whatever I do, don't let me say something that stifles innovation.
Let's pick up with that theme because you got a little agitated, I noticed. A little excited.
I'm sorry.
You're passionate.
That's his
You're
style.
You're passionate about the problem because you obviously see this as a great problem. and this flood of data, what do we do with it? For example, you were mentioning all these different tests at the end. Are physicians going to feel threatened that their patients know all about these tests and things, and are going to try to second guess and what their prescriptions are, or what kind of diagnosis they are? If the data is available to them, they take it home, they look at it, or are they going to become junior doctors now? And will the doctors feel threatened by that?
Speaking of books, I just wrote a book called The Doctor in the Mirror. It's just will be out on your bookstores shortly. But the thesis of the book is look in the mirror and you'll see the best doctor you ever meet. And it's basically trying to, again, reemphasize this notion of empowerment. There's no question that the thesis of your point is that the traditional confines of the patient-physician relationship are undergoing a profound change. And so the balance of power has certainly shifted. The physician always had the power because they had the knowledge, the information, and the patient had nothing. Now the patient has equal egalitarian access to information, probably has more information about their particular rare disease than the physician does. However, that's a good thing. The challenge is the patient is going to have an awful lot of struggle trying to make sense of it. They will certainly need to understand it to what they can do to implement it, but also understand it in terms of their own values, needs, and preferences, which is fundamental. But at the end of the day, there are tough choices that need to be made, and they're going to need some counsel and guidance. The physician will have a hard time. The other place where this is, though, I think the most challenging, is the physician is being bombarded with a lot of data, too. They're getting a lot of data from delivery systems, feedback from mobile app data will be coming. They're getting a ton of stuff. And the question will be is that now most doctors don't even have the most rudimentary of electronic medical record systems. And so now we're going to have to figure out what is a value proposition with enough of a return on investment to get physicians to buy into electronic systems that will allow them to analyze data and be able to organize it and then feed it back into an intelligent conversation with the patient. We are a long way from figuring out how to make that link come together.
Eric, you were shaking your head on all these points.
Well, I think one key point we have to recognize is that, and you touched on it, Ira, that the access to the data. So currently, the medical profession, at least as represented by the AMA is lobbying the government hard that the public should not have access to their DNA data. They shouldn't have access because they wouldn't know what to do with it, and that it's dangerous and it has to be mediated through physicians. Well, at the same time, there have been surveys done of physicians, tens of thousands of physicians, and it's shown that 90% of physicians don't feel comfortable dealing with genomic data in terms of helping their patients. So I like the doctor in the mirror concept because, you know, when the internet was started in the 90s, it was sort of thinking about empowerment of information, and there wasn't the information. Now, with sequencing, and it's that person's DNA, who could be more vested in the ability to prevent conditions, which I couldn't agree more. That's where we have to shift to. You're not dealing so much with the chronic disease burden, which absorbs more than 3/4 of the healthcare budget. So I think that part of our problem is we don't have, as a medical profession, we have not let go. And we're still having one of the major lobbying forces to try to hold back the data from the people that deserve. It's their data. They should have it.
Greg,
You know, I think there are 2 points here. One is about the power of the doctor versus the power of the patient in this equation, and then the other is this policy issue of our healthcare system in the United States is fee-for-service. And so to the extent that that's going to always be there, we will drive ever more services to be used. We've had an interesting experience at Life Technologies. We have thousands of employees in the United States, and so we went to this Safeway plan a few years ago, a consumer-driven healthcare plan that basically tried to turn that model of fee-for-service on its head, gave our employees a sum of money and said, now go do your healthcare. And then obviously put in a ceiling for catastrophic care when needed. And the change in psychology of our employees over the last few years has been amazing. Because now they have precious dollars. They'll decide where they want to spend it in terms of what technology could make a difference. And I think this is a model that at least should be considered more and more because it puts the power back in the patient versus this whole dialogue of should they have access to the data or not. It's insane. It's their data. It's their journey. It's their outcome they should be responsible for and obviously they have the most vested interest in what happens here.
So you're basically saying that we have to look in the mirror again and become our own physicians so we know how to spend. If we're given a pool of money, we have to figure out how to spend it. Do you think most Americans Doctor, you think most Americans can do that? They can figure out how to ration their own health care and where to get it and decide how to use it?
One of the things I have learned as a fundamental principle, I used to be a jazz musician and played fairly aggressive jazz. Never talk down to the people. People are much smarter than we think they are. And so I have enormous confidence in folk. Having said that, it would be terribly unfair to the American people to turn them loose on this great frontier of a world unsupported by either new kinds of education or access to coaching. And they're going to need that. I think one of the great challenges that is raised by what Greg is doing is genetic counseling. People are going to have to make some very tough choices about their health and intervening on their health based on probabilities. Ira, you spend a lot of time, and you're much more smarter than I am about the quality of science education in America's high schools. But I have a suspicion that Americans are not well trained on understanding probabilities and are not well trained to be prepared to make fundamental decisions like whether I get a prophylactic breast mastectomy based upon a probability of such and such amount that I may get breast cancer. Those are tough choices. And so one of the things that I think, if as an entrepreneur in the audience, we will need to be thinking about is how can we solve for the ability to provide cost-effective access to people that kind of information that allows them to become learned, to become literate, to become smart, and make those kind of choices. And I think that because I know that as Eric's thesis in his first comments were that if you leave it to the medical care system to figure it out, we'll never do it. We need to call in the Army. And the Army is at CES. And the Army understands how to use consumer-friendly, social network-oriented technology to be able to help move people from point A to point B. We're going to need all of that if we're going to have any chance to be successful with what Greg has done.
So you're saying that crowdsourcing your problem might be a solution?
Well, yeah, there's already evidence for that. There's people's lives were saved through just posting their condition and picture on Facebook. So we already have evidence that crowdsourcing through lay people, no less through interactions with the medical environment. So, but participatory, I mean, that's the key. We don't have that now. We except for
tell me what you mean in detail, participatory.
Well,
what does that mean?
What we have now is we have all these advertisements for drugs to ask your doctor, right? And that works really well. That's an incredible investment. We have more men with erectile dysfunction now than it works really well. So the point is that when you get a person participating and saying, like a perfect example, which is wrong in our country right now, a drug Tegretol. Tegretol is a widely prescribed medicine for various things like neuropathy and migraine and whatnot. And in Taiwan, you can't get a Tegretol prescription without having a genotype to be sure you're not going to die with Stevens-Johnson syndrome. Now, the incidence that is low, 1 in 10,000. But you know what? There's hundreds of thousands of people getting new prescriptions with this drug. In this country, there is no genotype for that drug. So I had a colleague of mine whose wife almost did die in the hospital because she got Tegretol for trigeminal neuralgia, and then she was in the intensive care unit, and she didn't get the genotype, which should be available. So why shouldn't, as an example of participation, the doctors aren't doing it. They don't feel comfortable with genomics. You get a prescription for Tegretol, say, gee, I better get this checked because I don't want to take this risk. And that's the kind of example of participation that we need to have in our daily practice of medicine.
I think you touched, go ahead, did you want to speak?
No, I'm in total agreement with this, but you also have to come back then to the incentives of what will make the patient want to participate much more actively in seeking out these answers and being a much more vigorous participant in their own health. And again, if healthcare is essentially free, then you're never going to fully engage. And I think that is one of the underlying issues as well.
When could healthcare ever be free?
It is free.
It is?
Most employers, let's say on the employer side,
yeah.
Most employers haven't moved to a program that we have done. And I'm not advocating that. I'm just simply saying there's a change in psychology when you have to see what actually is being spent for your health care, and there are limits to how much could be spent for you. it changes how you think about it.
I think what Greg is getting at, and I think he's on to something important, is what he's saying is that still most Americans do not suffer personally for the financial consequences of the health choices that they make or the choices that they don't make. So that as they become sickened and ill from preventable illness and need to interact with a very expensive medical care system, they're not paying the bill. There's no financial incentive. And so what Greg is, I think, getting at, and we certainly agree, we sell a lot of these products, and we're seeing the biggest uptake in all the things that we do on our insurance side of our business has been the uptake on the kind of products that your company is buying. But what I think is critical to what Greg is getting at is he's talking about aligning incentives. So instead of having a war between patients and the people and their employers who pay for their care, a war between patients and physicians as they battle each other out, what we're sort of trying to figure out is how can everybody sort of be aligned in the same way. So patients now have what's called skin in the game financially. That's saying the choices that I make, if I decide to go to a physician or a hospital that is not very good and I have bad outcomes, and we knew that they weren't very good, then I have to be involved in that decision. I have an incentive. If I know that I have risk factors for diabetes and I don't change my behavior, then I won't get a benefit on as a cheaper insurance product. So we're having that. But what's also important is the physicians who are caring for those people are now being moved off of Eric's, which he doesn't like correctly, fee-for-service, moving into what's called an accountable model, where you are now accountable for the quality of outcomes and the financial performance of how you treat a population of people. What that means in a nutshell and very succinctly is that there is an incentive for the delivery system to identify patients who may be sick early, keep them from becoming ill, which is the same incentive that the patient has for their benefit design. And now you're starting to find a new paradigm in healthcare where you're aligning everybody's financial incentives. And then the notion is, how can you support that with new tools, new capabilities, which come from the digital health revolution?
Let me just turn that situation around a little bit, and because I agree with you on the point you made before about trust being very, very important, trusting the whole system. You talk about diagnosing early and prevention. What about people who say, I now can look at my human genome and I can see on it that maybe I'm susceptible to diabetes, I'm susceptible to some health disease, and my insurance company is looking at the same data and is going to say, I'm not insuring you now because somewhere down the line you're going to come down with this illness and I'm going to put you in a different pool of people who are higher risk. And people are afraid of that, and it's a matter of trust.
No, there's no question about it. I was fortunate enough a few years ago, and for several years, to chair the Secretary of Health's Advisory Committee on Genetics, Health, and Society. Our number one as a group, and my number one personal agenda, was to make sure that we did everything we could to pass legislation for non-discrimination for genetics. We have pretty good legislation. And so I would say to you that there is legislation that prevents that kind of behavior. Every one of us has, when you get down to the genomics that you've described, Greg, a pre-existing condition for something. And so there's good legislation. It needs to be continually revisited and enforced. So at the end of the day, that sense of trust was absolutely important, and I think we've attended to it, but of course we need to be ever vigilant about it.
All right, I'm about to give out a phone number because I'm so used to it. I don't have a phone number to give out. Step up to the mic if you have some questions. We have some time to take questions. So what's the first step? You talked about the healthcare system is ossified. You talk about it. We need huge changes. Is there a roadmap?
Well, we have a model.
What's
the
the
model that Reed described about an accountable care organization, which is going to take a long time the way it's mapped out with the current administration. Kaiser Permanente. They're into prevention. They've got great electronic health records. They want to get digitized everything. They want to get into genomics. That's a pre-existing model that works. It's not fee-for-service. They get away from doing tests and procedures for unclear purposes. And so we've seen it work.
You know, there is one roadmap, actually, that people might find interesting. And we've had it for 10 years. It's called, and I would urge you to go back in your search engine and pull up something called Crossing the Quality Chasm. The Crossing the Quality Chasm report comes out of the Institute of Medicine of the National Academy of Sciences, and it basically is a roadmap for the redesign of the American healthcare system. What is so frustrating when you go back and you look at that report is how little we have come down the road. But it predicts and describes almost everything we talked about. The need for patients to have access to their information, the need for free flow of information between two patients and between patients and their physician, the need to respect a patient's values, needs, and preferences, the need for healthcare to be outside of a face-to-face setting and to occur in non-traditional environments 24 hours a day, 7 days a week. It describes the need to be able to predict risk and promote health because of early identification. It's a beautiful document, and I would just urge you, if you have any interest, go back and pull up Crossing the Quality Chasm. Just read the executive summary. You're real smart people. It'll take you like 5 minutes.
Yeah, but there was one thing about that. That in 1999, when the Institute of Medicine came out with this, it said there were 100,000 people being killed in hospitals each year. And I said, oh, this can't possibly be. And then last week, the government released a report that 1 out of 7, it's more than 100,000, 1 out of 7 of the major reports of adverse events that are occurring in hospitals don't even, the 6 out of 7 don't even get reported. So the first step is don't go into a hospital.
You don't want to be sick.
Don't want to be sick.
Yeah,
that's
hospital's
why
the worst place to be if you're sick.
Remote monitoring saves a lot more money.
Well, is
than
that
just,
possible?
Yeah,
Is that possible?
yeah.
We keep people at home or are getting cared home by digital health.
You got it.
But so I know we got people there, so let's be real quick. But Eric, this is extremely important. I talked about, again, I cannot emphasize enough the problem of the escalation in healthcare costs. We cannot afford, I'll just tell you real quick now, there will not be any more money spent. You can't. The federal government is absolutely unable to deal with Medicare expenditures any further. There is 40 out of 40, at least 40 of all of our states are in financial deep doo-doo, which means Medicaid is, deep doo-doo is a heavy economic term. But if you look at the impact of that they are in such trouble that their Medicaid programs are going to be seriously jeopardized. And as you know, there is no discretionary resources anywhere in any state for education. So we got real problems. And then every American corporation, big and small employers in particular, cannot afford it. So the picnic is over. So my point is getting people out of the highest cost centers. If you are thinking about where you really want to make a difference, one of the most, although I don't want those, I still want to, hopefully everybody gets in love with prevention and helps to deal with that. One of the most important areas that Eric is getting into is this remote monitoring so that we can get people out of the highest cost centers and get them out into lower cost centers and be able to do that work by less skilled, less expensive personnel. And so this remote monitoring thing is exceedingly important for the future, not only of healthcare in America, but for the economic survivability of America.
Okay, let's go to step right up to the mic, sir.
Good morning, Kamir Ferry, Johnson & Johnson. This is a question regarding coaching. Earlier when the prokaryotic genomes were introduced, I was working with them, and one of the things we experienced was that there was a lot of data, and the computer scientists were making a lot of inferences and a lot of incorrect inferences. And I think the science, until the scientists came to the play and basically coached them, the data was really not helpful. Today, I think a best analogy would be taxes. Taxes is something that we all have access to. It's ours. But we need coaching to get a correct endpoint. So the question is, who is going to be our coach? What is your vision of that coach? Is it the insurance companies? And if they are, having legislation of discrimination is one thing. But how do we prevent them to step into the game where physicians, and I work with dermatologists and rheumatologists all the time, they're not comfortable with genomic data. So I concur with Dr. Topol. So who is going to be our coaches?
Well, I think as this genomic age unfolds, there are going to be many new skill sets required. Certainly inside, if it does stay inside the hospital, a molecular pathologist will become critical, and you'll see that employment rise quite substantially. And then also, as you say, genetic counselors are going to have to be here in this equation, this interaction, and there are clearly not enough of them in our country.
So do you think you could, in the future, you might have a degree in genetic counseling, something like that?
Well, there is.
There is.
But
and there will be a lot more of them.
Yeah.
But there's only 2,500 in the whole country.
In the whole country, exactly. So,
So
this is going to be, if you have a person who's now moving into their career, a great place to get their career going is genetic counseling.
So think about it also this way. You've got a lot of people, you're going to have a lot of information that people will have no idea what to really do with. And when they decide that they're going to do something with it, we will have a potential, think about the PSA thing for prostatic cancer. So you got just all the men in America who are now terrified, or should be, trying to figure out, do I get a PSA test? If I do I intervene or do I just ride it out? How do I make that choice and decision? Who's going to help me to think that through? Part of it is a conversation between me and my wife or significant other, right? And because it has, the decisions will affect everybody, if you follow me. So there are real choices that families have to make. This gets back to needs and values. There's no coach that can coach you through that. That's a family conversation in the quiet of 3 in the morning, by yourselves. Then you got the science to work through. Does anybody know what the right thing to do is? Should you go and get an expensive surgery with all the other things that go with that and the subsequent medications that are required and yada, yada, yada? Those kinds of choices and decisions are tough. And at some point, people are going to need to not only have support for it, but the delivery system is going to have to start making some decisions. What is it willing to pay for? If you knew that you were bankrupting the future of your grandchildren because a gazillion men were getting interventions for a disease that maybe they shouldn't get, and were spending the money that should have been going to preserve your children's opportunity to have the kind of nation that they wanted, somebody's got to make those choices. And so I guess what I'll just leave you with is these are uncomfortable realities for which there is no czar to choose. And there's not clarity. Well, we will have a zillion of those to work through. And the challenge that all of us as adults will have to ultimately have is how does a rational society make those choices without stifling the individual freedom, yet not bankrupting the nation on wild goose chases that may not have optimal outcomes. Those are the decisions of a mature democracy, and I don't know whether we're up to it yet or not.
Thank you for that question. Next question, yes.
Good morning, Karen Klein, CEO of Silver Planet. Thanks for the thought-provoking conversations and exciting news. My question relates to changing. We all know the paradigm of healthcare is changing, and it's slow. But my question is to both the medical and to the media leaders, how do we convince both the consumers so that they are empowered because they don't understand? For example, as we all know, hospitals are now facing up to 3% penalties and avoidable readmissions for Medicare funding, and no one knows about it in this country who's outside of the medical community. And so how do we persuade or convince hospitals to change how they're looking at it, and how do we get, not just digitally, but how do we convince and persuade and empower consumers so they understand what's going on, so they feel like they can take control of their health?
That's sort of what a little bit of the kind of question I was asking before is, our consumers, are they able actually to make these decisions for themselves? And are we talking about counselors, genetic counselors, or anybody have an answer to that?
That's actually why I wrote a book on this subject, because I think the first step is educating. The earlier question about the coach. First, you got to have the players, then you can have the coach. So we got to get people to participate, to understand what are the choices of today, the knowledge of today, before we can then drive the next new phase of era of medicine. I think, unfortunately, on the hospital side, on the medical community side, that's largely being done through financial incentives that Reed has a much better grasp of. But I think the first step of us being able to have a new medicine that's much more precise, that caters to that individual, is for the individual to know what the opportunities are. And most people don't know about that yet. And that's what is a serious unmet need today. On the physician side, education is desperately needed because most physicians don't understand genomics, I've already mentioned. There's no medical school curriculum today that teaches wireless medicine, remote monitoring, genomic medicine as it exists today. So we got some problems. There are some potential solutions for that. We can have a Khan Academy for physicians. We should have that, but we don't have anything going yet. So these are sort of things that there are some solutions, but I think a lot of it is education and activation.
Well, you know, you talked about one of the biggest challenges of preventable disease is obesity. I mean, there's an education. Is that an education, or is that something like smoking, which you had to drag people by the hand into, and you know, by the government taking a part in that?
So the part of the answer is, if you think about tobacco, tobacco is, depending on how whether you're a glass half empty or a glass half full person, tobacco is actually a remarkable story. We have decreased tobacco consumption by about 25% over the last 10 years. We are now down to 17.6% or so of the population smokes tobacco. And we saw a pretty good drop last year over the year before. So the good news is we're down. The bad news is 17-some% of the American people still smoke tobacco, and there will be 440,000 people that will die this year alone from tobacco-related illness, and it will cost us in the billions to treat what they have. The point that I think that his point is that the way we got there was by a combination of education, cajoling, legislation, regulation, laws, a draconian enforcement of things in bars and restaurants. Right. I mean, and then it was a cultural shift that all occurred simultaneously. The obesity is going the opposite direction. We are absolutely seeing no breaks. There's no good news hardly on the horizon, left to its own devices. Now, what I am enjoying is on my mobile apps and on my iPad, I absolutely have there, my diet calculators. Every time I eat a donut, I have to confess to my iPad. I haven't had a piece of chocolate cake since I started recording because I cannot confess, that number of calories. I love these apps that do those things. I absolutely have every step I take and the speed with which I take it is monitored by my app, and I load those things in and I calculate the calories. So I'm living this whole reality. So I think, though, that where the thesis of the question and the point is, if we only brought to these conversations what we have been bringing, we will die. If we can bring another way of thinking, which is using the social network, using the integrating the apps into my regular life and pushing information into me every time I decide that I'm going to look at what's around me. And I'm going to then go walk, and it's going to give me a map to tell me where to go. And then I go into that place, and I just do one little thing, and it tells me what the nutritional content is of what I'm about to eat. And I like the song that I hear, and I push a button, and I get that song. And then I download that song with another button. And then I go back to my room, and then I go to the gym, and I want to exercise, and I put my thing on, and I hear that song, and my heart rate goes up 44 beats higher than it would because I like the rhythm. I don't know whether I just did health or I just did life. And I think being able in the middle of all that to have somebody say, by the way, let me give you some evidence-based science information about how to make some choices, because obviously we see what you're struggling with. All of a sudden my education happens without somebody making it a big news story or a pamphlet I had to read. So this is where I think the genius of CES community is about, is you've got to bring a different way to get to folk, because the old ways of doing it ain't going to work.
Okay, next question there. Thank you.
Hello, thank you. My name is Barry Loesch, and I have actually two questions. The first is, I serve on the Dean's Advisory Board for a large medical school in the Midwest. And one of the biggest challenges that I think we have, we're talking about educating consumers, but who do people trust with their health care? The first person they go to is their doctor. And why aren't we focusing on Eric's point about educating the medical students much earlier on? And my question is, what efforts have you seen, and what areas, what parts of the country, what universities have actually implemented within the medical school itself, within the curriculum, digital health types of technologies on genomics, et cetera, et cetera? That's the first question. Number two, That's the first question. Number two, on a related question, trying to push the cost of healthcare down, we're seeing, the fixed costs, of being within the hospital, they're having problems. Most hospitals are in the red right now because of the reimbursement under Medicare. What efforts have you seen in association with ACOs and other modalities of hospitals actually getting into the home care business? We're using telemedicine, using many of these other technologies, these digital health technologies, to actually expand the revenue opportunity for the hospitals outside of the infrastructure of the actual hospital itself and into the home directly.
Eric, you want to?
Well, just on the education side, maybe touch on that. And not just the medical students, because that's such a small minority. What about the 700,000 practicing physicians?
Right.
So
CME
yeah,
related things,
we got
right.
it's a really important thing. We actually got a startup grant from the Life Technologies Foundation to look at this and to start to map out a curriculum. But we need more. There's nothing going on. The AAMC, or the whole Association of Medical College, there is no activity there. And so there's nothing going on in digital health and curriculums today in medical schools, let alone a CME activity. So it's a real serious problem.
That's a huge opportunity.
Yeah.
Well, it sounds like what you used to talk about in nutrition. No one ever taught doctors about nutrition. The lag.
Same thing.
Of years. Yes. Next question.
Oh, I just wanted
you want a
follow
second
up
part
on
about
the hospital question.
Yeah, the
the
home care question.
It comes back to this issue, and great question, and again, it comes back to this aligning incentives. So at the end of the day, and by the way, I want to make sure I don't sound Pollyannish. This stuff is not easy, and if I sound optimistic about this, you also need to read in a great note of caution about it's actually happening. So I want to be balanced and nuanced here. But the point being that hospitals have a huge amount of fixed costs that are inappropriate. They're too big. Their infrastructure is inadequate, and we've got to start to free up some of that capital and distribute it in other places. The challenge that these hospitals have is that the way that they make money is having beds filled, people in beds, people going to the emergency room, people coming into the hospital, people coming back to the hospital even once they've been treated. So the way in which healthcare is moving towards this accountability of outcomes for quality and cost is to stop the people going to the ER that don't need to be there, to get people not admitted when they shouldn't be admitted, to reduce the lengths of stay, and above all, absolutely cut off all these readmissions back to the hospital after you have once been there. So let's solve for those things. That is a revenue challenge for the hospital. So the hospital does have to now start thinking, okay, how can I make money, still have access to capital to do the things that we have to do, still be in business to serve the legitimate needs of people through a different model. And so now you're seeing hospitals buying up physician practices, starting to buy up and starting to develop new relationships. But we are at the beginning of that revolution. The economic models of that are complex, and they will be challenging for hospitals because it is very easy, as you described, to stroke out the hospital by simply turning off its oxygen, its flow of patients, and before it's ready to become more flexible, mobile, and agile. So we're at a decision point right now that is very complex. But that's where the aligning incentives are, and hospitals are going to see their revenue stream directly tied to how successful they are at doing the three things that I just sort of talked about.
And they're moving in that direction?
They are moving in that direction. There will be more clout to do it. You will see your federal government through CMS start to align it, and you will see the private purchasers of healthcare start to combine with that. So there will be a critical mass to sort of get that done. Having said all of that, and this is again for those of you that want to think about business opportunities, imagine then that you are a hospital administrator who has a bunch of fixed costs that they need to liquefy and get out of that so they become mobile, more agile and fluid. Then you start thinking about what can you design to help them become more efficient and thereby continue their operating margin at a lower overall revenue stream. This is the opportunity for some of you to be thinking very carefully about. But if you really just put yourself in the CFO's position of a hospital, how can I keep my margin at a lower volume? And that's where a whole new area of digital technology may come into play.
Okay, I hope that answered your question. Next question. Say we went away for a second.
I'm Justin Bieber. I've been wandering around for 3 days. I age very quickly. No, my name is Bob Goldberg. I'm with the Center for Medicine and the Public Interest. I have one quick point, then I have a question. The first thing is we could reduce the rate of cost increase very quickly by letting people smoke again. People died quicker, metastasized, and all that Social Security money just piles up. We could solve all those problems. We could tell the Chinese to stop increasing their spending at 20% a year, the African countries increasing their health spending at 20% a year. So it's not the spending itself, it's what we're spending it on. We got to spend our GDP on something. I'd rather spend it on living longer, healthier lives than other things. To Greg's point, in Indiana, people that did not have health insurance were given, access to 4 health plans with a health savings account, and with the condition that the money would stay in there as long as they did preventive screening. Initially, the costs went up. Now the costs are going down. And what the second step is that now people are being gene tested for their drug reactions. So it can work to integrate all these things. The question is, we now have an infrastructure, $1 billion infrastructure in Washington that is doing one-size-fits-all comparison of technologies. You know, that what beta blocker should we take as opposed to what Eric's talking about or what we can do now. You know, my daughter almost died because she had to go through 5 different drugs for her disorder. The health insurance company would not pay for the simple AmpliChip gene testing that we found out that she was a slow metabolizer. So my question is, how do we, instead of putting another barrier of innovation through comparative effectiveness research, why aren't we doing like what the Chinese or the Taiwanese do, which is get it out in the world, let it be beta tested by millions of people, and find better ways to do it? It's a loaded question, I understand, but
Eric?
I couldn't agree more with Bob's perspective. These are fantastic opportunities to make for not just more precision, prevention of serious side effects. I mean, everything that you can say. There's a lot of naysayers of the genomic medicine world. And they say, well, you know, we spend billions of dollars. What do we have to show for it? Well, you know what? The knowledge is there. Bob just outlined a couple of examples, and we're not using it. And it's really sad. It's just every day is another missed opportunity. So, I mean, I hope that we'll start to see an inflection of that and start to adapt the opportunities that lie there, because that is a great way not only to cultivate better care, but to also reduce the cost. The cost of a genotype, I mean, it's pennies to do a genotype. But the cost of a side effect or giving a drug lifelong that the person, you know, what's amazing to me is of the 400 million diabetics, metformin is the #1 drug that's used.
Well,
And that drug it doesn't work in 25% of people, and they don't even know it, and they just add on more drugs to that.
But he also raised a question of trust. He said, I couldn't trust the healthcare provider to perform the tests that needed to save my daughter.
Well, let me, I want everybody to like me and think I'm a wonderful guy. And so I keep, having to sort of deal with these nuances of balance. Let me just, again, reiterate my passion for innovation and support for it. Let me also, just to disclose, I'm on the advisory committee for the head of NIH. So I absolutely love this stuff, and Greg is now my new best friend with what he's done. But if you saw what was on my desk every day with the waste of healthcare assets because we don't know what works and we don't have a good sense of the cost effectiveness of the choices that we make, if you saw what that is doing to America's healthcare expenditures, and whether or not you like, and we all want to spend money on health because it's a beautiful thing to do, which I think is great, I still have to let you understand that there isn't any government that can pay more at the state, federal, or local level. There isn't any employer in a global economy that can pay more. So if we just sort of got it out there, let's just do it. The cost escalation would be so huge, and you just spent $1 trillion of your nation's dollars trying to get 32 million people access to health care. $1 trillion. That's just under, and that's not even counting for the economics of the increase in diabetes and obesity. My point to you as innovators is, you have got to understand that there is a level of responsibility for what you are doing. If you think that you can just come to America and say, I got a great idea. Oh, I love my idea. Everybody should buy it. And you're going to bankrupt small business owners who have mortgaged their house 2 and 3 times to try to make a go of it and who are trying to afford health care, that's not right. And nobody's going to let you do that. No one in their right mind would let you just continue to do things that you don't know whether they work or not. Do they work better than the existing things? So I think where I would come out with, and not to be on a soapbox about it, because there's a discipline here. We do need to look at new things within the context of how do we manage the disease today. Total management, all in. Does the new thing give us the chance to have better outcomes at lower cost, all in? And if it does cost more, is the value worth it to the society? I'm putting my bet on innovation will drive costs down because we are doing things today so inefficiently. The beauty about what Greg is trying to give us is, why should we manage a disease halfway downstream? What if we could actually get to the source of the problem that his technology is helping to identify and take all those costs out? So we've got to bet on innovation, but you cannot bet on innovation, just throw it out there, because no one in your country can pay for that kind of gamble.
Okay, next question.
Hi, my name is Christian Grant. I'm an app developer that I especially focus on Android apps for tablets and phones. And so I have a few questions. I mean, one app we are working on is trying to, on a tablet, create a vital signs monitor that will do the same thing as a $20,000 monitor in a hospital for maybe $1,000 or $2,000. So if you have 50 monitors in a hospital, that's $1 million. What if instead you could spend $100,000 using wireless technologies? I mean, you would have some sort of vital signs measuring devices, tiny. They're starting to emerge, and they connect to the tablet. So that's the hospital scenario. It would measure heart rate, blood pressure, and maybe blood sugar levels. The other scenario, and I thought that was interesting, someone mentioned it, why not share that with your Facebook friends? And it was maybe a joke, but
no,
what if you could easily share that information with your closest family and friends? So if I look at my monitor, oops, my brother, he's got a very high heart rate now. I call him and say, and ask him what's going on, right? And if I don't get an answer, I drive over and check in, or I see his blood sugar level goes up, or maybe it's my mother's blood sugar level, right? How big of an impact do you think both self-monitoring and close family and friends monitoring and being aware of your health almost every minute of the day? I mean, maybe they'll only get alerts a few times a day when it goes above certain levels, right? But how big of an impact do you think that would have on, let's say, healthcare costs in general, and how many lives could it save?
It takes a village.
Well, no, I think what you've just outlined, that's our best shot. You know, nobody has a solution to diabetes and obesity, and it is a runaway. I mean, this is beyond epidemic, pandemic. And the point is, if you have all the diabetics competing for the best glucose management, or competing for the most exercise and the nutritional status, that's our only chance. And there's good pilot data that suggests that could happen. Harnessing social networking, not for just socialization, but for better health care. And that's free, okay? That doesn't cost anything. We already have the infrastructure. That's the whole point. The digital infrastructure exists, and we're not using it in the medical health world until now. Maybe.
You know, I wanted to use this quote, and I'm glad you give me a chance to do it, because I think it's just great. It's from, everybody knows Clayton Christian and the stuff he did on the Innovator's Dilemma. But he had this quote, and I just thought it was useful. It says that many of the most powerful innovations that disrupted other industries did so by enabling a large population of less skilled people to perform their work in more convenient and less expensive settings, and do things that historically could only be done by expensive specialists in centralized, inconvenient locations. And I think that kind of disruptive stuff is exactly what you're getting at.
Okay. Interesting point. Yes, good quote.
Jim Harris, a Canadian journalist. We all think that knowledge, we just need more knowledge. And in fact, knowledge really doesn't cut it. You know, we have known for decades that smoking kills us, and yet it wasn't until social pressure was brought to bear and an emotional component. And perhaps Morgan Spurlock in Supersize Me has done more to get at the core issue about obesity and diabetes. He did that expose on McDonald's.
It didn't decrease McDonald's at all, that's for sure.
They've done well.
It actually changed McDonald's. They dropped the supersizing and introduced salads. But how do we we've talked a lot about the knowledge, but how do we get to that social and emotional component? It just came up now a bit with how do we create competition to drive down glucose levels for diabetics and so on. How do we bring about the social and emotional component to healthcare?
Well, if I heard you correctly, you were saying that this crowdsourcing or the Facebook apps is one way of doing that. It's getting people to follow each other, to bring it as part of the new social community. You know, we watch each other, we talk about things, we make it socially acceptable to do one thing more than another thing. You know, it's not socially acceptable to buy a giant burger, it's less socially acceptable. And people follow each other doing it.
And I also think these sites like Patients Like Me, which these two gentlemen are very familiar with, if you have a particular malady, that you can be with others on that journey and how you manage it, and that can be then a constituency that finds these other applications or these solutions, and it brings about the change that you need to hopefully bring about better cures. So there are, I think, a lot of interesting ways that are taking place now to bring people together, to bring that social pressure you're describing.
We have an app that we're having a lot of fun with. It's called Optimize Me, and you can see this if you go down to our booth here at the exhibit area. But it's basically a social networking competition sort of site, and basically, you know, I like to cycle, and I got a bunch of, you know, quite frankly, a lot of my younger colleagues, and so I'll say, this is what I accomplished today, and then they'll social network me and basically try to humiliate me by saying what they did, which of course means I get back on the bike that same day and go back out and ride another 30 miles just so I can, you know, and so this sort of sense of these, I think these social networks are really, really, really an opportunity. And I think we're just learning, just at the cusp of learning. See, what was for sure we did not, I know what does not work. Here's my brochure, Just Say No. I've got a very pretty 4-color brochure, by the way. Just Say No. I know what doesn't work is health fairs. You know, where you got lots of balloons and a clown and a boombox, you know, and everybody gathers together, right? I mean, those are cute and they're sweet, and you know, everybody gets a good feeling for a minute. But those aren't the things that are going to work. It's going to take these other things. And so I think this power of social networks, we've got to learn to harness. You know, the thing I hope we don't do is healthalize the social network. I hope we can take the health and ride into the social network as opposed to have a health social network. So it's ghettoized. I don't think we can ghettoize health on these things. I think it needs to be a part of the process of living. That's why I think these are going to be important.
Next question. We have about 5 minutes to go.
Diane.
Last question. You are the lucky last question.
I'm lucky. Diane Weiner from Hilarium. It's a technology platform, enables high patient engagement and management, designed for the hospitals as one sector. And so the question is environmental, looking at the entire picture, because I'm a healthcare consultant, live in the real world. How do we get the payers and the self-funded employers to share or to pay the hospitals for these new programs that they will need to reduce the readmissions?
It comes back to this aligned incentive. So, at least in terms of what I do every day, you know, we are definitely in with those hospitals, giving them the data that they need. I mean, nobody went. And what you've got now is, and we haven't talked about it, but there is something that is important called these health information exchanges. So what you're seeing all around the nation now is the delivery system is attempting to be connected by these macro data sharing environments where everybody dumps their data in and can pull data out. And so that is a revolution that will inevitably go forward. It's not, in fact, in my opinion, going fast enough. But I think that we're starting to see the free flow of data and information that was called for in 2001 in the Crossing the Quality Chasm report. The challenge is going to be, how can we get enough coherency so that you can bring data from different systems together in a cost-effective, administratively efficient way. That means data dictionaries, data glossaries, the mechanisms of how data will flow, so that you can actually do this. What I fear is, in everyone's great attempt to share information and share data, we are building such huge data silos that the administrative costs of trying to aggregate it and then analyze it, liquefy it, and then disseminate it back out, that those administrative costs may dwarf the economic savings that come from the quality. So again, back for those of you that are entrepreneurially minded, is can you become geniuses to help everyone else figure out how do we move this data from point A to point B in an efficient way? How do the vendors, the software vendors, be able to write their code in a way that has standards that make sense? How do you then be able to, at the level of scale of the amount of data we're talking about, be able to really analyze it and then liquefy it quickly and then flow it back out for those decisions? The theoretical model is there. The practical way of doing it in a cost-effective way is still lagging a little bit.
Well, hopefully we've given you stuff to think about for the rest of the Digital Health Summit. You'll watch stuff through the lens or through the filter of what we've talked about today. I want to thank all of you in the audience for joining us today. Also thank Greg Lucier, Reed Tuckson, and Eric Topol for being with us this morning. You're welcome. See you on Friday.
Good seeing you. One quick thing. So I mentioned before, Scientific American was our amazing media partner. We have a media booth that they're going to be doing some interviews and things in. And I really wanted them to say just a quick word. Bruce Bramfin is Vice President and Publisher of Scientific American.
30 seconds to summarize 167 years. Just kidding. Thanks, Ira, Reed, Eric, and Greg for this, and thanks to our friends at all of it at Life Technologies. Thank you for being here. As Ira said, you're going to be shy about coming up to the microphone. Well, we had to ask 6 or 7 people to sit down. I don't know, what do we do for an encore? At the Digital Health Summit, Jill and I were talking about that. Thanks, Jill Gilbert, for putting this all together. What a fantastic way to kick this off. Scientific American has always been on the edge of what's next. We are now at this pivot point. I hate to be Malcolm Gladwell-ish about this, but the tipping point has been reached, and we've got complexity happening in the world like this, and we've been behaving like this for too long. So this gap, the complexity gap that we're addressing here, is at a critical point, and we've got to do something about it. That's what Scientific American has always been about. We haven't really ever participated in CES in a big way, but we did this year because of this subject matter. So thanks again, everybody. Have a great show. We'll see you later.